Hi, former colleagues and friends. Very good evening. Assessment part 3 of SOAP. We are here. We spoke to the patient. We got what are their complaints. According to them, what is their experience. And we got the objective things. And in the objectives, we did some physical examination. We did some radiological examination. We did some laboratory examinations. We went through the reports of other clinicians before the patient came here. The past medication history is all known to us, and current complaints are listed down, right, in both subjective and objective. Remember, in assessment, many of us repeat the same sentences what we wrote in subjective or objective. With subjective and the evidences from the objectives, how did we arrive at a particular diagnosis? The patient came with a major problem and there may be some minor problems associated with it, right? But the major problem is called as the diagnosis. Now, giving a clinical reason on how did we arrive at this said diagnosis is called assessment. We assess the patient's status as told by the patient and as recorded, as proved by the laboratory values, radiological values, physical examinations, and other which have got evidences, we arrive at a diagnosis. Now, assessment is a therapeutic model to identify the issues or the problem. Everything has got a model. See, treatment has got a model. There is a therapeutic protocol. First line treatment, second line treatment. The same way, there are 2-3 diseases with the same kinds of signs and symptoms, right? So, we need to clarify by giving examples or by giving reasons from the subjective and objective why it will not be the other problem. Suppose a patient comes, says that there is a pain in the chest, right? The pain in the chest, there is inability of breathing or shortness of breath. There is decrease in RBC as per the objective, and the patient is suffering already from ulcer 2 to 3 times. It may be GERD, it may be angina, it may be regurgitation of the acid that is causing the burning sensation in the chest, which is misunderstood by the patient as pain, whether the pain radiates or did not radiate. Nowadays, the angina or the pain is not radiating. Without radiating, there are silent attacks. So, how did we arrive at a conclusion that citing the ECG, citing the radiological reports, citing the other reports, the pulse rates, the heart rate, or ECG, etc., and the past clinical records of the patient, by giving this kind of differentiating diagnosis for one disease may have the signs and symptoms similar to that of 2 or 3 other diseases or problems. And that's how we need to separate or we need to eliminate the other problems and identify and finalize with proof, with data, with record that this problem is this because of this. Maybe there is no one problem. The list of problems which are put in a numerical list. Thus, all these problems can be identified and we can give reasons and finally arrive at a major problem. There could be 1 or 2 minor problems associated with it for which we can plan the treatment, right? But please remember, do not repeat the subjective and objective statements here again. Now, how the patient's condition progressed or regressed over a time? What factors contributed to the regression or progression of the patient condition from, say 3 days they are experiencing the pain and now they have come and admitted? How did it progress in these 3 days? It increased, it decreased. What all the other symptoms that came in, and what does the lab report says? For example, if I take a psychiatric case or a psychological case, psychiatric case, there is an increase in anxiety of the patient, and this increase in anxiety meets the criteria for generalized anxiety disorder. This will be the final diagnosis statement. The reason is it meets the criteria for GAD. You are not saying it yourself. There are various criteria for generalized anxiety disorder which the patient meets, the condition of the patient meets. And so, considering what they told in subjective and considering that the GAD criteria are also checked, both of them are matching, and so we finalize the diagnosis as GAD, generalized anxiety disorder. Now, in assessment, there will be one sentence with the description of a major problem, and we can list the problem. There can be a numerical list of all the problems identified, 1 2 3 4 5 other problems. Right now, with everything that we say as a problem or a diagnosis, we need to have a support, the proof. Every listed problem should be supported by subjective and objective findings. We have to dig deep into all these findings, and if anything is insufficient, we will have to go for it, right? But just like that, don't mention that for a osteoarthritis patients, they have taken only X-ray. Let us refer CT scan, MRI scan, and all those things. See, we are not here to extract money from the patients, right? So we need to say very clearly that the X-ray itself shows the damage, X-ray itself shows that there is a gap, and the other parameters from the blood test and other things are showing that there is an inflammation. So we can stop at that level also. I'll give you an example. Finally, an assessment is listed like this. In low back sprain, it is low back sprain caused by radiculitis involving the left fifth LS nerve root. This is what is the final statement. And one more statement, as I told you, increase in anxiety of the patient meets the criteria for GAD. This is the final assessment. Now, minimum two differential diagnoses has to be given for every major problem, which we don't do when we present normally in our day-to-day practices, which we need to practice. See, elimination is very important. There are many diseases where signs and symptoms are going to be the same. So how do we say that this is not angina? This is, burning of, burning sensation in the chest region. That is because of the GERD. It is not because of angina. So how are we going to differentiate two or more similar conditions that has got the same kind of signs and symptoms is the key in assessment. So there we need to eliminate the things which are not going to, and how are we eliminating it? We have to give the proof support from subjective and objective. Based on this assessment, the diagnosis is finalized, and then based on the diagnosis, the treatment plan is outlined. The treatment is differentiated into short-term treatment and long-term treatment, and the treatment should also be measurable, because the subjective and objective parameters or the signs and symptoms should come down with the treatment. So the treatment, the outcome should be measurable, and the treatment should be measurable. When the treatment is measurable and the outcome is measurable, the signs and symptoms will also go away, which are measurable. Right? So assessment should be comprehensive and concise. In the end, please remember, we should not repeat what is written in subjective and objective. We should give differential diagnosis. We should practice elimination criteria. And so we have to arrive at the final diagnosis, which will be the basis for the treatment plan outline, which should also be measurable. Now, how should an assessment be? An assessment should be comprehensive. Comprehensive meaning it includes everything. We should not miss anything. But it should be concise. Concise means KISS. Oh, what is KISS here? KISS is keep it short and simple. Concise should be everything is included, but it should be very brief. It should be keep it short and simple. We have to name it very clearly, like the low back sprain caused by radiculitis involving left fifth LS nerve root. We should not confuse it again and again. The diagnosis has to be clearly emerged based on the support or the proofs that we get from subjective and objective. So remember, an assessment should not include stories, should not include, blah, 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 all the things that are written in subjective and objective, and again we have presented it as assessment. No, why am I saying that this is anemia? Why am I saying that this is not angina and this is GERD? Why am I saying that this is not rheumatoid arthritis but osteoarthritis? So we need to say why this is this and why this is not those two things which has got the same kind of symptoms and signs. So keep it short and simple is concise, but we should include everything. To keep it short and simple, we should not exclude anything, right? So this is what is assessment, the third part of SOAP. Thank you.